Welcome to the Funnel Effect. Today we're doing a deep dive into hypertrophic cardiomyopathy, or HCM. It's a really complex heart condition, and it actually affects way more people than you might initially think.
Absolutely. And we've centered our discussion today around a major piece of work, a very recent comprehensive review article. It was published in the New England Journal of Medicine just last month, September 2025, authored by the renowned Eugene Braunwald and his colleagues.
Right, Braunwald, so a heavyweight source.
Exactly. And it's critical because it really synthesizes how much our understanding and, crucially, the treatment of HCM has, well, evolved. It's been a massive shift.
So our goal here is pretty straightforward. Cut through that complexity. We want to give you a quick but still really thorough understanding of HCM. We'll cover the genetics, the risks which have actually changed over time, and importantly, the latest treatment breakthroughs. Some really exciting stuff happening there.
Yeah, definitely. So maybe starting with the basics. HCM, at its core, is a pretty diverse disorder. The main feature is this thickening hypertrophy of the left ventricular wall.
The heart's main pumping chamber.
Precisely. And often it's specifically the basal interventricular septum, the wall between the ventricles near the top. But the key diagnostic point is that this thickening isn't caused by things like high blood pressure or valve disease, what we call abnormal loading conditions. It's intrinsic to the muscle itself.
Okay, and the prevalence you mentioned. It's not some rare condition, is it?
Not at all. That's one of the biggest misconceptions. The review highlights it affects approximately 1 in every 500 adults worldwide.
Wow. 1 in 500. So if you think about like a large concert or a sports game.
Yeah, you're talking potentially dozens, maybe even hundreds of people in that crowd who have HCM, many perhaps undiagnosed. It's surprisingly common, yet often flies under the radar.
Which leads us perfectly into the genetics,
Right.
right? Section 1. The sources really hammer home that HCM is the most common inherited heart condition caused by a single gene defect.
That's right, the most common monogenic cardiac disorder. This isn't something you typically acquire, it's largely inherited.
So it runs in families.
Yes, that familial link was noticed early on. And that observation eventually led researchers back in 1990 to a landmark discovery, identifying a specific missense mutation in the gene for cardiac beta-myosin heavy chain.
And that discovery was huge, wasn't it? It sort of shifted the focus.
It completely changed the game. HCM went from being just a structural abnormality you could see on imaging to a problem we could trace back to the molecular machinery of the heart muscle itself.
Now, when we talk about genetic testing for HCM, two terms pop up a lot: gene positive and phenotype positive. Can you break down that distinction? It seems really important.
It's crucial. Gene positive means someone carries a known pathogenic gene variant linked to HCM. About 40% of people evaluated for HCM fall into this category.
Okay, 40%. And are there main culprit genes?
There are. The two big ones are the gene for beta-myosin binding protein C, that's MYBPC3, responsible for maybe 45% of gene-positive cases, and the beta-myosin heavy chain gene, MYH7, accounting for about 35%.
Got it. So that's gene positive. What about phenotype positive?
Phenotype positive means the person actually shows the physical characteristics of the disease, the clinical signs or functional changes, like the thickened heart wall seen on an echo or MRI.
So it can be gene positive, but not yet phenotype positive.
Exactly. And that's a critical group. These pathogenic variants, they fundamentally mess with the heart muscle's engine, the sarcomere. They often increase its sensitivity to calcium.
Which makes it contract harder.
Right, leading to this state of chronic hypercontractility. The muscle is basically stuck in overdrive. It also becomes incredibly inefficient, burning through energy reserves way too quickly.
So like a souped-up engine that's always revving too high and guzzling fuel.
That's a great analogy. It leads to energy starvation, fibrosis scarring, and eventually cell dysfunction and death. It's this underlying mechanism that the newest drugs are designed to target. We'll definitely come back to that.
Okay, so back to that person who's gene positive but phenotype negative. They have the genetic potential, the faulty engine blueprint, but the heart hasn't thickened yet. Are they in the clear?
No, unfortunately not. They carry a significant risk. We call this the risk window. They need careful long-term follow-up because they might develop the actual phenotype of the thickened wall, the symptoms later in life. The gene doesn't always express itself immediately or fully. That's called variable penetrance.
So early genetic screening in families with known HCM is vital then.
Absolutely vital for identifying these at-risk individuals.
And clinically, when the phenotype does appear, the symptoms seem incredibly varied.
Hugely varied. Some people remain completely asymptomatic for years, discovered incidentally. Others experience things like fatigue, shortness of breath with exertion, that's dyspnea, or chest pain, angina.
And that angina the review mentions is often particularly bad in HCM.
It can be, yeah. It's a double whammy. The thickened muscle itself demands much more oxygen than normal. But simultaneously, as the heart wall gets thicker, it can actually squeeze down on the small coronary arteries running within the muscle wall.
Wow, so it restricts its own blood supply.
Exactly. Reduces the internal diameter, the lumina, of those vessels. So you have increased demand meeting decreased supply. That's a recipe for significant angina. And of course, there are more severe outcomes too. Arrhythmias, fainting spells or syncope, progressing to heart failure, or tragically, sudden cardiac death.
Which brings us to diagnosis. The main tools are imaging, right? Echo and MRI.
Correct. Echocardiography, or echo, is usually the first step. It's widely available, relatively inexpensive, and often decisive for initial screening. It's also good for detecting obstruction of blood flow out of the ventricle.
Especially if you provoke it.
Yes, using maneuvers like the Valsalva straining or during exercise echocardiography, that can bring out an obstruction that isn't obvious at rest.
But for the definitive picture, especially for risk assessment.
Cardiac MRI, or CMR, is really the gold standard for non-invasive imaging now. It offers much better spatial resolution, letting us measure wall thickness more precisely.
And it sees things echo can't.
Critically, yes, it can detect late gadolinium enhancement, or LGE. This shows up areas of myocardial fibrosis, or scarring, within the heart muscle. And the presence and extent of LGE is a very important variable when we're trying to assess someone's risk for sudden cardiac death.
Okay, that's a perfect transition. Let's talk about that risk section too, the evolving threat. Historically, the big fear with HCM was sudden cardiac death, SCD, especially in younger people.
Yes, absolutely. Before effective prevention strategies, SCD was the most common cause of death in HCM patients, particularly younger adults and athletes. The annual incidence was estimated around 1% per year.
And the cause is usually electrical.
Typically, yes. Ventricular fibrillation, a chaotic, ineffective heart rhythm, often triggered by the electrical instability arising from that disorganized, scarred, hypercontractile muscle tissue.
But then came a major invention in the 1980s. The implantable cardioverter defibrillator, the ICD. That must have changed things dramatically.
Revolutionized the field. For patients identified as high risk, maybe they have a strong family history of SCD, or their heart wall is extremely thick, say 30 millimeters or more, or their ejection fraction has started to drop below 50%. For those patients, ICDs have been incredibly successful.
How successful?
The incidence of SCD in high-risk HCM patients who receive an ICD for primary prevention is now less than 0.5% per year. It's a massive reduction. We've largely managed to short-circuit that risk of sudden electrical death for many patients.
But that success story creates a new narrative, doesn't it? If people aren't dying suddenly as often, they live longer with the condition. So what's become the primary concern now?
You've hit it exactly. With the success in preventing SCD, the main long-term clinical challenge, the major cause of morbidity and mortality now, has become progressive heart failure.
And this is where that weird paradox with the left ventricular ejection fraction, LVEF, comes in. Normally, a high LVEF, like 70%, sounds great. But in HCM...
Right, in HCM, you often see what's called a supernormal LVEF, maybe 70–75%. The heart is squeezing very forcefully because of that hypercontractility. But the core problem in HCM isn't usually systolic, the pumping out, it's diastolic.
Meaning the relaxation and filling phase?
Exactly. The muscle is thick and stiff, so it doesn't relax and fill with blood properly between beats. So when the LVEF in an HCM patient does start to drop, say below 50%, that's actually a really ominous sign.
Why so ominous if 50% still sounds okay in other contexts?
Because it suggests that the underlying disease process, the stiffness, the energy starvation, the fibrosis has become so advanced that even that hypercontractile systolic function is finally beginning to fail. It's like that engine running on fumes has finally sputtered. An LVEF under 50% in HCM is often considered analogous to maybe 35–40% in typical systolic heart failure. It indicates severe end-stage disease.
Wow, okay. So managing that heart failure then involves either tackling the obstruction, if present.
Yes, through medications or procedures we'll discuss. Or, if it's non-obstructive or therapies fail, treating it aggressively like standard heart failure, which can ultimately lead down the path towards needing a heart transplant.
And one more complication we should touch on, atrial fibrillation or AFib.
Yes, very common. Affects about a quarter of symptomatic HCM patients. The high pressures and stretching in the atria make them prone to AFib. And in HCM patients, AFib is particularly dangerous. It significantly worsens symptoms and carries a very high risk of stroke from blood clots.
So prompt anticoagulation is key.
Absolutely essential. As soon as AFib is detected, no delays.
This really sets the stage for the management breakthroughs in Section 3. For years, the treatment options were pretty limited, focusing on symptoms.
That's right. Beta blockers have long been, and still are, the recommended first-line therapy, especially for obstructive HCM. They slow the heart rate, giving it more time to fill, and reduce the force of contractions somewhat.
And if those weren't enough,
Then doctors might try non-dihydropyridine calcium channel blockers, like verapamil or diltiazem, or sometimes a drug called disopyramide. These also help reduce contractility and obstruction.
but the review makes a crucial point about these traditional drugs.
Yes, and it's the setup for everything that followed. While these drugs can definitely help manage symptoms, they have not been shown to change the underlying course of the disease. They don't stop the heart muscle from getting thicker or more scarred over time.
Why not? Were they just not hitting the fundamental problem?
Exactly. They were managing the consequences, the fast heart rate, the outflow obstruction, but not that root cause we discussed. The excessive actin-myosin cross bridges driving the hypercontractility and energy drain.
Which brings us to the paradigm shift.
Yeah.
The cardiac myosin inhibitors.
Precisely. This is a completely new class of drug designed to directly target that core mechanism. They inhibit the excessive formation of those power-generating cross bridges between actin and myosin in the heart muscle cells.
Mavacamten was the first one approved. How does it work, and what did the big trial show?
Mavacamten essentially encourages the myosin heads, the motors of the muscle, to spend more time in an energy-sparing detached state called the super-relaxed state. It dials down that hypercontractility at the source.
Okay, like putting a governor on that revving engine.
Exactly.
Yeah.
And the results from the key Phase 3 trial, Explorer-HCM, were quite dramatic. Compared to placebo, mavacamten led to significant improvements in exercise capacity, peak oxygen uptake, and in patients' functional class, their symptom severity.
And importantly, it reduced the obstruction.
Massively. It caused substantial reductions in the pressure gradient across the left ventricular outflow tract, that blockage. The average decrease was around 3742 mmHg, which is clinically very meaningful.
That sounds amazing. But there was a catch, right? A safety concern that led to special FDA requirements.
Yes, there was. Because mavacamten works by reducing contractility, that's its intended effect, a negative inotropic action. If the dose is too high or isn't managed carefully, it can reduce the heart's pumping function too much.
Dropping the LVEF significantly.
Correct. In the trial, about 4.6% of patients had their LVEF drop below 50%. This led the FDA to mandate a risk evaluation and mitigation strategy, or REMS program, which requires regular echocardiograms to monitor LVEF and adjust the dose carefully to avoid excessive reduction in function.
Okay, so powerful but needs careful handling. Then came the next drug in the class, aficamten. Similar results.
Very similar efficacy results shown in its main trial, Sequoia-HCM. Similar improvements in exercise capacity, symptoms, and reduction in outflow gradients.
Does it have any advantages over mavacamten, perhaps related to that LVEF issue?
Potentially, yes. Aficamten has a significantly shorter half-life than mavacamten.
Meaning it washes out of the system faster.
Exactly. So if a patient's LVEF does start to drop, stopping or lowering the dose leads to a quicker recovery of function. This might make dose adjustments easier and perhaps safer. It also appears to have fewer significant drug interactions.
So potentially a bit more user-friendly in clinical practice.
That's the hope and the potential advantage.
So the clinical implication now is that these myosin inhibitors, mavacamten and aficamten, are recommended for adults with obstructive HCM who still have significant symptoms despite being on those first-line therapies like beta blockers.
Correct. They offer a targeted approach that wasn't available before. And the big hope is that they may reduce the number of patients who eventually need invasive procedures to relieve the obstruction.
Let's talk about those procedures now in Section 4. For patients whose symptoms don't respond adequately to medication, septal reduction therapy, or SRT, comes into play.
Yes, for patients who remain severely symptomatic, typically NYHA class 3 or 4, despite optimal medical therapy, SRT is the next step. There are two main options.
The first being the traditional surgical approach.
Right, surgical septal myectomy. This is open heart surgery, first developed back in the 1960s. The surgeon directly removes a portion of the thickened septal muscle.
And it's considered the reference standard.
Generally, yes, especially at experienced centers. It allows the surgeon precise removal of muscle, and importantly, they can also address other structural issues at the same time, like abnormalities of the mitral valve, which often contribute to the obstruction in HCM. Long-term outcomes after myectomy are excellent, with very low mortality rates.
Okay. What's the alternative, the less invasive option?
That's alcohol septal ablation. This is a catheter-based procedure done in the cath lab. A cardiologist selectively injects pure alcohol into a small coronary artery branch that supplies blood to the thickened part of the septum.
Causing a controlled heart attack in that specific area.
Essentially, yes. It creates a small, localized infarct, which causes the muscle in that area to thin out and scar over weeks to months, reducing the obstruction.
Who is this procedure typically for?
It's often preferred for older patients, those who might be too frail for open heart surgery, or sometimes when surgical expertise isn't readily available. Recovery time is much quicker than surgery.
Are there downsides compared to myectomy?
The main one is a significantly higher risk of developing complete heart block, which often requires implanting a permanent pacemaker. The gradient reduction might also be slightly less predictable than with surgery sometimes.
Okay, so two options for severe obstruction. But what about the patients without obstruction? That's about a third of HCM cases, right?
Yes, a significant group has non-obstructive HCM. They don't have that outflow tract gradient, but they still have symptoms, often severe ones related to the diastolic dysfunction, the stiffness, and that energy deficit we talked about.
And treating them has been tough historically.
Very challenging. Symptoms like dyspnea and fatigue can be difficult to manage. But there's exciting news here too. The myosin inhibitors, mavacamten and aficamten, which were initially studied mainly in obstructive HCM, are now in phase 3 trials specifically for non-obstructive HCM.
So potentially a new avenue for them.
A very promising one. Additionally, other approaches are being explored, like metabolic modulators. There's a drug called nirogacestat in trials, which aims to shift the heart's fuel usage, make it burn glucose more efficiently to try and combat that energy starvation state.
Fascinating. Okay, let's look further into the future. Gene therapy seems like the ultimate goal for an inherited disease like HCM.
It really is the holy grail, and there are several strategies being actively investigated now. One is genome editing, using technologies like CRISPR to try and directly correct the faulty gene in heart cells.
Wow, actually fixing the typo in the DNA.
That's the idea. Another approach is gene silencing, using things like small interfering RNAs, siRNAs, to basically turn down the expression of the mutated gene, reducing the amount of faulty protein produced.
And a third way.
Gene replacement, particularly for mutations like those in MYBPC3, where the faulty gene leads to not enough functional protein. There's actually an ongoing phase 1b trial looking at delivering a healthy copy of the MYBPC3 gene to heart cells. Early days, but incredibly exciting.
It really is. And the other big future trend seems to be earlier detection, using AI.
Absolutely. Artificial intelligence has huge potential here. Researchers are training AI algorithms to analyze routine tests, like standard 12-lead ECGs or even basic echocardiogram images.
Things people might get for other reasons.
Exactly. And these AI tools are showing remarkable ability to pick up subtle patterns that suggest underlying HCM, even in people who are currently asymptomatic, perhaps those gene-positive, phenotype-negative individuals.
So AI could flag people who need further investigation, potentially years before they develop symptoms or complications.
That's the goal. It could potentially identify a large, previously unrecognized population with HCM, allowing for much earlier monitoring and possibly preventative interventions before irreversible damage occurs. It could fundamentally change when and how we diagnose this condition.
It's truly remarkable how far things have come. From just describing the thick heart muscle to understanding the precise genetic and molecular causes, and now developing targeted therapies like these myosin inhibitors that directly address that root cause.
The progress has been astonishing, particularly in the last decade or so.
But it does leave us with a really important, almost philosophical question about these new drugs, doesn't it? Given that their effect, calming that hypercontractile state, wears off fairly quickly if you stop taking them.
Yes, that's the critical question going forward. Since the myosin inhibitors don't permanently alter the underlying genetic defect, but rather modulate its effect, will patients need to take them for life?
Right. Is lifetime administration going to be necessary to maintain that benefit, to keep the sarcomere in that more relaxed state long term? And if so, for whom? Will it be all gene-positive individuals? Only those with symptoms? Obstructive versus non-obstructive? These are the crucial questions for the next phase of HCM management.
Determining the long-term strategy, the necessity of potentially lifelong therapy, and defining the right patient subgroups. That's really where the research and clinical focus will be heading.
A lot to think about. Thank you for watching The Funnel Effect.